Ladies and gentlemen, you are more than welcome to this second series of live international webinars through the kind courtesy of MI-CathLink, that is an educational platform sponsored by Highnoon Pharma to promote knowledge and skills in complex coronary interventions. We all know that significant calcium in coronary arteries requiring PCI is challenging for interventionists. A choice of debulking device to deal with calcified lesion is therefore critical and important in order to have a quicker and successful procedure outcome with minimal complications. Now, before we take you to Freeman Hospital, Newcastle for a live case demonstration, I would like to introduce the international experts in the discussion panel that we have today. So we start with our great friend and colleague. I have the pleasure to introduce Professor Zhang, who is a consultant interventional cardiologist and professor of medicine and vice president of Nanjing First Hospital, Nanjing Medical University, China. He is a high volume operator in complex coronary interventions and structural heart disorders. He has authored more than 80 manuscripts, including ultimate definition and decay crush trials, published in world-class journals. Then I have the pleasure to introduce my colleague, Dr. Jenny Rosington, who is a consultant interventional cardiologist and a high-volume operator doing more than 300 complex interventional cases, including left main bifurcation and calcified coronary lesions in Leeds Teaching Hospital, which is a tertiary care hospital and has a massive volume of intake of primary PCIs, complex left main calcified lesions, and also structural heart disease. Now, she is a director of the Cath lab at Leeds General Infirmary Hospital. Now, I'm pleased to introduce Dr. Chu Jim, who is a consultant interventional cardiologist at Cardiac Vascular Central Hospital, Kuala Lumpur, Malaysia. He regularly performs complex percutaneous coronary intervention at Malaysia, and he is one of our colleagues, Dr. Rosalie, who is the part of the family of Pakistan Life. Before we take you to we now have next our panelist, Dr. Bashir Hanif, who is the medical and executive director of Taba Heart Institute, Karachi, Pakistan, performing complex coronary interventions. He is past president of Pakistan Society of Interventional Cardiology and course director. And next we have Professor Nadeem Rizvi. He is an eminent cardiologist, interventionist, and immediate past president of Pakistan Society of Interventional Cardiology, and performing complex interventions. And he is also a trainer and a certified proctor of TAVI procedure at Karachi. And now we have Professor Zubair Akram, who is the president of Pakistan Society of Interventional Cardiology and course director of Pakistan Life. And then second last is Dr. Asad Akbar, who is also from Pakistan and has a vast experience in rotablation and complex structural heart interventions. And last but not the least, Professor Hakim. He is an upcoming cardiologist. I was just introducing him from Pakistan. He's a program director of interventional cardiology and director Cath lab of National Institute of Cardiovascular Diseases. He is board certified in various cardiovascular specialties and performed complex coronary intervention and coronary structures. Now, I think this is the time that we now go to Freeman Hospital, Newcastle, where I think Professor Mohammed should be ready with his case. Now, Mudassir, can we take all of us to Freeman Hospital, please? Right, so now you can see Professor Mohammed Agrid, and he is a course director alongside with me, and he is the operator today. Let me have a brief introduction of Professor Agrid. He is a professor interventional cardiology at Freeman Hospital, Newcastle upon Tyne. He is an international proctor and physician trainer and a faculty member of the numerous international meetings and a regular live case operator demonstrating complex coronary interventions, including coronary total occlusions, adjunctive devices such as rotablation and laser. Professor Agrid is in the top 3 highest volume operators in the United Kingdom, with special interest in complex and high-risk interventions and surgical turn down patients. He is the clinical lead for cardiovascular research at the Newcastle Hospitals NHS Foundation Trust and has over 100 peer-reviewed published papers. He's a great friend of us. Now, Professor, agreed now all to you, and we are keen to start and see the case, please. Professor Zhang, in your lab, you have all this dedicated system all the time, or you have to hire, or what do you do normally? It's part of your institute. You are muted.
Pardon, you means
these live cases?
Yeah. So in our Cath lab equipment with light transmission equipment. So I think for the education purpose, we can do the live case every day for the nationally or globally. Yeah.
Yes, because you see, you are a very busy center. You must be. Professor Chen is always there. You see, whenever we request him for Pakistan Live and any interventions, so they transmit a lot of live cases. So, Paul, any success from your side?
Well, welcome to the Freeman Hospital, Newcastle upon Tyne in the UK. It's really a privilege to be doing this webinar and demonstrating some treatment of complex calcium treatment and how we approach it. So we have a 67 years old gentleman who was with us a few months ago with acute coronary syndrome, and he had an angiogram which showed 3 vessel disease, occluded small OM, long segment of disease in the LAD. That he was discussed at the JCC, and because of he had previous TIA and a stroke, posterior cerebral flow, he had hypertension, atrial fibrillation, and some sleep apnea and asthma. He was deemed to be high risk for surgery. Yeah. So in September last year, we treated his LAD, which was quite a marathon. We ended up using IVL, laser, and rotablation. Matter of fact, we've written his case up. My colleague here will be presenting it at some stage. So with this in set, I wanted to start with the radial artery, but his radial artery is not palpable, so we went right femoral artery 7 French. Cases like this, it's better to set yourself for success, because I know from what we did last time in the LAD, that's going to be very resistant. So anyway, can you see the angiogram?
No, not yet.
Okay, can we put the angiogram up, please, so you could go forward one? So as I said, we had a 7 French or 6-7 femoral artery, a 7 French guide. But this is the angiogram of the left system. Can you see it now?
Yes, we can see that.
You could see the tortuosity and even the calcium in the LAD. And this was in September. It was a CTO in the mid-LAD that required, as I said, laser, rotablation, and proximally we used IVL. And luckily, this seems to be quite okay. The OM remains occluded, and it's a co-dominant system, but I don't think it will be. So here's the right coronary artery, which is the target today. But I'll kind of draw your attention to the LAD on the right side of the screen, how tortuous and how calcified it is. The same thing with the RCA. You could see it without any angiogram.
Modan, it's a bit darker. Is it any clear picture or any other view? Because we can see that.
We are going to go for the next one.
Okay. That's better.
And this is the RCA, RAO. Next. And this is an BA cranial. So, any comments?
Yes, we can see. I mean, it's a tortuous, calcified, diffusely calcific. Let's have the opinion of the panelists. First of all, I would request Professor Zhang, we start for you from China, and see what are your thoughts about this case. Professor Zhang.
Yeah, from the baseline angio, it's a very tortuous here, the severe calcification and diffuse lesions. So for me, I think I will also choose a 7 French guiding cassette. Maybe if the radial artery is large enough, I will transfer from the radial approach. Of course, I will select this M+ guiding cassette, which will give a strong support. And another thing, I think I will use intracoronary imaging guidance.
Wire, please.
Yeah. If it's severe calcification, especially superficial, and also the around the arc angle is more than 270 degrees, I will use a rotablation for this particular calcification lesions. Thanks.
Thank you. Jenny, what do you think about this case? You do a lot of IVL and other cases. Any comments, please?
Absolutely. I mean, the setup sounded ideal. 7 French, a supportive Amplatz guide would be perfect. Looking at the calcification, you can see just angiographically modification here is going to be needed, particularly given the fight you had on the left. Often if one vessel has been tricky, it proves true that the other one would be. As much as imaging is going to be really crucial here, I do have some practical concerns of actually just being able to deliver the IVUS round that proximal tortuosity. So I probably would be looking to use imaging to guide future, but maybe just going up front with rotablation, mainly due to the length of it, or orbital, which also we have access to here. Orbital might be something quite nice in this vessel, but certainly modifying and having a low threshold for doing that up front.
Right. Now, can we have opinion? Sorry, one opinion from Pakistan. We have limited use of IVUS and the rota. Anyone from Pakistan? Short comments, please.
Yeah, I think I agree with Jenny. I think definitely we need to IVUS this, but practically there will be a problem delivering the IVUS catheter through that tortuosity. I do believe, I think we need to undersize the burr a bit, maybe 1 to 5 burr for those tortuosities. And I feel that might not be enough. So we might end up using IVL or cutting balloon after rotablation with a 1 to 5 burr.
Right, thank you. I guess, Mohanad, what do you think?
Right, well, I think it's all valid comments, and absolutely this was my thinking. I was setting up to do an orbital atherectomy. Orbital atherectomy is a new kid on the block, as you know, for calcium modification. It's a little different from the rotablation because it has a crack, almost like a shock into the arteries. However, there are some consideration to be taken into account when you're doing this. The main one being any dissection. I tried to wire this artery with a Corsair and a Fielder FC wire. I could not. So what I did is, if you could see my angiogram right now, I took a Caravelle over the Gladys MG wire, and we passed the Caravelle distally. Thankfully, it did pass. Very, very resistant lesion. Of course, I've got the IVUS ready on the table. However, I don't think it.
Mohanad, this is Bashir. Yeah. I don't know, somehow your image is very small. I'm not sure, is that so? Everyone is.
I mean, we could change it for you. Can you put the image on the bigger?
Bashir, you can, if you can.
Can we put the image on the bigger, make it bigger, please? The image, just instead of this. Or can we change it? Yes, can we change it?
Bashir, have you tried that double click? Sometimes you're not in the gallery view, you have a small image. So try that.
No, I am on the full screen. I'm on the full screen view.
Well,
and
Bashir, this seems to be the only way we could do it apparently. I'm not sure.
Okay, that's all right. That's fine, no problem.
If you are struggling, I'm struggling the same here because the images are not the best. He's a little bit overweight. He's 125 kilogram. Hold on to this.
Yeah, okay.
And of course, 125 kilogram, the X-ray degrades, and we don't see very well. But there we go. We have to deal with what we have. So yes, so I managed to wire it with the Gladys MG, pass the Caravelle down. Let's flush it and keep it handy. And in the interim, with all the kind of resistance back and forth, the guide catheter, the AL1, caused a small dissection in the ostial RCA. To go forward.
Can you show us the image? Yeah, that's fine. Okay.
Sorry, go back one. Here you go. That's the last image after I put the Viber wire down because that was my plan. Can you see the dissection proximity? Yeah. Can you see the images?
Yes, we can see that because it is not so easy because it's tortuous and calcific.
Can't see the image. It's a black screen at the moment.
Oh, sorry, you can't see them.
Yeah, it's very small and very difficult to see. Obviously, the weight and other limitations, but it's difficult to appreciate dissection.
Paul, can this be changed to a bigger screen?
Bashir, are you sure you are seeing? Because my screen is quite good enough to see that is okay. And if you see your change, try to change your gallery.
Because they're showing the small one where the picture was.
The screen was all right before you changed it.
Take a 1 to 5 burr, please.
If you double click on the screen.
Okay, but if I mean, I know I appreciate the difficulty. We're trying to see if we could change this.
That's okay.
I'm not sure we
That's
can.
Okay.
Yeah.
You carry on. That's all right.
So at the ostial RCA.
Quick comment.
Yeah, go on.
So I can't really appreciate where the dissection is really because of the quality of my image. But just a quick question for everyone on the panel. Let's just say this is a dissection that extends proximal, and given the tortuosity, how many of you would really feel comfortable getting a burr across? The angle is quite angry, and getting a burr could be potentially problematic.
Yes, I agree.
I'm not sure there is any other option, Hakeem. If it's dissected, I think you need to do a quick few burr runs to get your workhorse wire across and maybe balloon and then stent it. But if it's already dissected, it's a major dominant RCA, and it was hard to even wire it. As long as we use a small burr, maybe short runs and pretty very careful advancement, I think we should be okay.
Let's open the fluid.
Mohammed, have you?
I mean, I think that's a very, very valid comments about the dissection and about how you approach this. In the majority of my cases, when I'm doing rotablation, I will be using. Is there pressure? Can we wang it up 350? I always use extra support wire and hardly ever start with 125, except for cases like this. Very tortuous. There's a huge potential for problems here. And this is the time where I use the floppy wire, the floppy rota wire, and the small burr. And of course, as mentioned, you really have to be quite careful. Listen, when doing it with the dissection it could be an issue. We do rotablation in CTOs where there's a lot of subintimal space and dissection, but that's a little different from this one. This one is at the top of the artery, and that can be potentially problematic. I'm going to try to dynaglide through that dissection into the true artery and just do this very small short runs and really controlled approach, so we don't have to run into trouble. Of course, the other difficulty here, this is a codominant large right, and I think we probably are going to have, hold on just a second, we are going to have bradycardia. So I usually don't put temporary wire anymore, but in this case, we might have to. The way to over, sorry, just want to complete this point. The way to overcome the problem with the bradycardia, to do short runs and just let the artery drink blood and the debris finish, and do it very slowly and very gently. To be patient, basically. Go on.
You mentioned about orbital. Are you using orbital atherectomy or the rota?
I was going to put orbital atherectomy, and I put the Viber wire down, but when seeing this, the dissection with orbital atherectomy is not, it should not be done.
And
at least for the timing.
Yeah.
Yeah.
And
the tortuosity. Yeah. The tortuosity could overcome it by gliding the orbital atherectomy distally and doing the burring retrogradely. And this is the advantage of the orbital atherectomy. You could burr retrograde. Can we put this at 170, 180?
Dr. Hakeem, you were saying something.
Yeah, just want to sort of add on. I concur that at this point, of course, there's no option for orbital anymore with the deception. But even having said that, seeing the anatomy, the tortuosity, and the proximal segment. Personally, I'm a bit more cautious with orbital for the tortuous segments. I don't think that the orbital takes the bends that well. Of course, what Mohammed said was correct. You can have the option of sort of sending backwards first rather than going forward. But I will probably go with rotational atherectomy at the first go rather than orbital. And also, I'd just like to know, I mean, personally, I would put in a temporary wire right from the start here, rather than wait until we have a problem for putting a pacing wire. How many of us will put a pacing wire, or anyone using aminophylline for this?
Yeah, I was going to say aminophylline, giving 50 milligrams sometimes tends to help. But you have a dissection going in, I would expect no reflow or compromised flow during the course of the case. So now would be a good time to at least have venous access if one is not being obtained yet.
Yeah, I mean, look, I take that point on board and I totally agree with it. The only thing is, you're going to have to push the button and come with me. For the last 7-8 years, I only used one temporary basing, and we do lots of these cases. You have to be patient. Okay, dynagliding, come up with it. Don't touch that button. It's this one. Okay, go on. You have to be patient, you have to take your time, and this is a very difficult artery. This is a potentially hazardous, to be honest, but we have to be careful. Keep coming, don't stop coming, keep coming, don't stop, keep coming. Push the button. Push that
Starting
button.
with 1.25, Mohammed.
Yes, absolutely. This is the one of the only cases that I would use 125 because anything bigger could be problematic here. Okay, stop there. Stop. So I bypassed the dissection with the burr on Dynaglide. So hopefully that will protect me. As I said, I'm sorry I was going to demonstrate.
No, I know this. It's not a straightforward
But it
case.
is, we have to kind of adapt to what we have. Now, I'm suspecting he will go into bradycardia. So we're going to have to do very short runs. But here we are. Can you see my screen?
Yes, now we can.
Okay, so you can see that I bypassed that ostial dissection. Of course, when you have ostial dissection, the last thing you want to do is continue to inject. But this seems to be holding because I changed the angle of the guide. So we're not probably splintered that little dissection. And I'm just about to start burring. Yes?
Mohammed, you think dissection was caused by the catheter or the wire?
Yes,
What
no,
caused your
catheter.
Catheter,
When I was
okay.
trying to deliver the Corsair, it was stuck in the proximal lesion. So I tried to take it out and I could see the guy dived. And it dived in a kind of unfavorable angles. It caused that dissection, but we managed anyway.
Yeah.
Given the difficulty you had delivering the Corsair, Mohammed, did you have any concerns taking a Caravel through
Sure,
as your
absolutely.
choice? Yeah.
I mean, but what's the other option is there was no other option. The difference between Corsair and Caravel is you can spin the Corsair, you cannot spin the Caravel. Well, you can to a certain degree. You just have to be really, really careful how you handle it, because if the tip gets stuck in the lesion, it could easily come off. So you're not supposed to spin the Caravel. You push the Caravel, but you know, a little bit of spinning, which I use clockwise and anti-clockwise, so it doesn't build any tension and that tip doesn't come off. It's really how you handle it. So it looks probably okay. So I'm just going to be very cautious here because we are going to have a dissection, I think, no matter what we do, which might be okay here. Okay.
How was hemodynamically the patient?
Hemodynamically is okay so far. And so come to the lesion, let it work a little bit and we'll come back. Again, just because the potential also with this case, if the burr gets stuck and the wire's on a bend, you really have to be very careful how you activate your burr, because the wire, the burr could cut the wire and then the burr will just jump out. So you have to be very, very careful. And it's obviously so that it is one of these cases that has changed anatomy since I've done him in September. So, but we arranged for him to come and to have this done. So we have to deliver it. It's not the most, I mean, it is very educational in all honesty, but it's not the easiest cases to be done as a live case. But there we go.
No, this was very difficult. When I saw the pictures, I thought that this bend will cause a problem. So maybe when you stand this,
to go to areocranial.
I think it's
maybe
the
that
one question.
Yeah,
what speed are you going to start at? I have a tendency to starting really fast. I start at 185 and then go higher.
Keep going cranial. Yes, well, I put it at 180. Yes, I usually use 180, 185, but I think we might have to do, I'm just being cautious how I'm approaching this. You could see the bend, so that you could see the severe bend here. And you can see the little dissection, but I think it's all contained and we should be okay. Quite often an extra support wire would be really helpful here, but in the same token, it could she's cut through the artery. She end up having more, I don't think I see it go to be acranial. So we'll just take our time. It's not there's no rush in here. You have to really be very, very, okay, here we go. So that, look at that bend in here. I mean, it's, yeah, so we'll have to be very, very gentle, very, very slow. And of course, I'm pulling the burr because it is potential you could cut the wire and the burr will just jump out, which I don't want to happen, obviously. We'll just take our time. So far, his heart rate has held very well, hemodynamically very stable, but we're only burying the very proximal part. So I think this shows you dealing with calcium nowadays is really one of the most, it would have been ideal if we could have used the IVL, but of course, when you have the IVL would not pass in here. If the Corsair did not pass IVL, no chance. And I know the new IVL balloon that's going to come to us in the next 2-3 months It's going to be a little less, the profile is smaller, but it's never going to be a balloon that you could start in cases like this. And of course, it's going to have more pulses up to 120. But, you know, so I'm going to keep checking in here slowly to make sure that I store that again for me. So is that what everybody will do, or is there any other approaches people would use?
Anyone?
Consider it's angulated lesions. Would you consider change a super stiff or low wire to give more support?
Yeah. Oh, here we have the first time we have some bradycardia. As I said, 99% of my cases I do extra support. In this case, I was a little cautious because I've seen the extra support wire, because of how stiff the artery is for perforation. But it's absolutely one of the. But as you could see, I pushed my extra or floppy wire all the way down, so I could try and have some good support.
Man, I think this is an excellent case to show
using a rotor stiff here. Using a rotor stiff would bias you towards the outer wall, and
absolutely. You could see now we're starting to affect the, because he's going down bradycardic a bit and then he recovers. And that's what we do quite often. We are very impatient, but I think I'm taking my time. I think it might be boring for some of the audience, but this is how this needs to be approached. There's no rush. You rush, you run into trouble.
Jenny, you want to say something, Jenny?
I was just saying that this is an excellent case to sort of demonstrate that having one calcium modification technique available is not still ideal. There's been talk about whether orbital will take away what rotor does, but I do think there's a place for all of it. And what you start off thinking a case may be, as things change and evolve, you know, we could well be using IVL subsequently for the deeper calcium in due course. In this case, so it's an excellent demonstration.
So go back one. Can we watch this now? So basically what I do with all rotablation, you come to the lesion, let the burr work for a few seconds, depending on the hemodynamic and the heart rate, and come back. And here I did it a few times, and now on the last time, very gentle pressure, and the burr has gone. And this is what you have to be aware of. If there's any resistance and you push, this is where you end up with perforation. Because the burr, especially on a floppy wire, the floppy might bend and go out of the artery, and the burr will follow it. But in cases like this, take your time. This is the only thing I would say. Be patient. It's not a virtue for interventionalists, but we have to be patient when we're doing this.
And is this a substrate for where the burr can be stuck, actually? Is it?
Sorry?
Can the burr can stuck in this lesion for such?
Absolutely. The smaller burr, if you don't take your time and allow it to create or to shave the calcium and create a channel, it could jump through and get stuck. And this is one of the advantages of the orbital atherectomy, because a burr stuck, there's nothing on the back end of the burr to bring it back. And there's multiple things you could do, obviously, but you don't want to be in that situation. Orbital atherectomy, on the other hand, you could burr retrogradely, and that could, but in the same token, when you have a severe lesion, because the orbital atherectomy is a crown, it's not pointy like the rotablation, it might not pass. But on the glide, tortuosity, on the glide with the orbital atherectomy, it usually does, but not in all cases.
Just as a point of discussion, I think for such as tortuous lesions, we know how much the atherectomy is dependent on the wire biases. So for such tortuosity, you use such a stiff or extra spot wire. So you're just worried sometimes the biases might be more likely to induce some vessel injury or perforation. There is also an option of actually treating the band with some balloon modification IVL rather than the bird all the way through. So some have been, I mean,
IVL, I don't think it'll ever pass in here with this situation. I said the Corsair on a stiff wire did not go. So an IVL will be very difficult to deliver. But we have made some progress here in terms of going through the lesion. So I'm going to try one option to see once I've done this is the Dynaglide through it. You can see that it's still resisting. But we've done okay here. Go to LAO. And the bradycardia is still happening, but not as much. So we'll let the artery drink some blood, and we'll just take my time, because it's only the two lesions I want to treat, the proximal one and the one after it, and then we could reassess. 125, I don't think will be doing the job, but this is where I might switch to the IVL, because a bigger burr could be a big problem, I think.
Do you change your strategy? You see this the speed of the burr in tortuosity, or nothing to do with the speed?
Of course. I mean, the speed, as said, for me, up to 1.5, I always put it 180, 185. You could go to 200, but 180, 185, what I do. Bigger burrs, about 155 to 160. And it is just, I mean, the speed may help, may not, but the main thing is for me is not to change the speed when you're operating inside the artery. So I am going to try to dynaglide this and see if I could get into the. I'll stop it there and dynaglide it. If I suspect it is the angulation that's causing us the problem here, but we'll.
And I
It's
think
gone.
I won't any more.
It's gone
any
on
more
dynaglide.
pictures now.
Sorry?
I
go
said
back
I
one.
won't take any more pictures at
Yeah,
this point. I think on your last picture, it looks like the dissection. I mean, you are somewhat protected because you have calcium downstream. The chances of getting a fillet all the way down a spiral
Yeah.
is low, but I would be careful with ejecting through that aggressive AF.
Absolutely, absolutely. I think I'm worried about the aorta more than the RCA, but if we dissect the RCA, that'd probably be easier to deal with the calcium. I mean, with the CTO, you have a heavy calcium, you go around it by knuckling in the subintimal space. So, but I mean, the proximal lesion, I passed it now with dynaglide, which tells me I've done enough work, at least for this burr. So now I'm going to go do this middle one. And then once we've done that, we'll take the burr and reassess our situation. I think IVL seems to be probably the next step for me.
Muhannad, would you try doing an NC balloon first before you go on for IVL, or are you going to go just?
Yeah. I mean, it's possible. That's probably what we should do. But in this case, again, when you come into the mid lesion, there's a lot of calcium. Having a little bit more bradycardia, but I'll give him his time to drink for the blood to flow and clear the debris.
I think now might be a nice time for imaging. Once you've created the potential chance that now.
Yeah, absolutely. One of the things about rotablation, again, is just to take your time. Honestly, there's no rush. You try to rush, and that's when you run into trouble. You could do everything right, and you still run into trouble. Come to the lesion, let the burr work, depending on what's happening, come back, let the blood flow and clear. And that's what we need to do here. The art is. So here we go. You need to be watching for the deceleration of the artery of the burr, obviously. In theory, anything more than 5,000, you should not keep burring, because that's when you create more heat and more dissection. So this is why you see me here. I'm doing probably about 5-7 seconds in these lesions. I said it might be boring for somebody watching, but this is the step that you need to do in highly complex, highly tortuous and loss of calcium. Anything else, you run into trouble. And despite all this, I said I might still run into trouble, but I'm hoping not.
Yeah, my concern is that 1.25 may not do that much, considering the lesion was there, obviously, but it wasn't really that like 95 or 99%. And if you go directly to balloon, that may not work, and you are definitely going to need either a bigger bar or IVL or something before you could even try the balloon.
Yeah, no, I totally accept that. And the 1.25, as I said, I hardly use it except in cases like this. And quite often I'll upgrade. So now I think we'll do the 1.25 image and see what we have. Because as you know, there's a lot of people who store that. Just a very gentle injection, not too much pressure. A lot of people only use a small burr technically to kind of modify the lesion. I don't believe in this. And this is where we're spending a lot of money. Of course, I'm going to be doing the same here, in fact, but where you do a small 1.25 in a 4O vessel, and you know it's not going to do much. And then so it's not expanding. Let's do an IVL or let's do laser or whatever it is. But in this case, you have to be judicious, really. Very tortuous, highly calcified. If I take a big burr, there's a potential for much more problems. The option would be to change to an extra support rotawire and take a bigger burr. But I'll decide this once we've done finish with these runs. And once I've done the IVUS, as you saw, we crossed the distal lesion. I'm going to do it one more time. So you see if we've gone through it. And again, I'm just doing it once because he goes bradycardic, but we'll give him a couple seconds and he'll recover. Okay.
I don't know how you found that, but with orbital, I found patients hemodynamically tolerating it much better, whether that's because of the slow speed that it's mandated that you use, or whether it's just the particle size is much smaller, but they seem to tolerate it very well.
You're absolutely correct. Yes, I think that is the because also you have to do it very slow. The way it helps with the calcium is different from rotablation. The particles are smaller. So that, and now we're going to take this out. So if you come to this side for me, I don't know how people do it, but quite often I don't screen. I don't even going up or coming down. All what you need to do is just, I'll show you just what we do here. We'll take it out of there. Okay, so here you go.
So you're using RotaPro?
RotaPro.
Now that you modified the thing, I know you don't believe in it, but what about trying an NC balloon and see if that can cross and you can dilate it enough? Maybe
that's absolutely what I'm going to do.
Most of the calcium.
Yeah, that's what I'm going to do.
Get some good device down.
That's what I'm going to do. Okay, close that. Stop the. Yeah, that's what I'm going to do. As I said, and my rationale for that bigger burr he could be created. Take the white bit away from me. A bigger burr could be me asking for a problem, but it might be the only option here. We'll have to see. I'll take the IVUS now and we'll have a look and see, and then we could decide together. Because one of the pathognomonic effect of throat ablation, when you see the reverberation in the artery of the calcium, of course, once you passed, the main thing is to make sure. Okay, is we have a flow, there's no perforation, all under control. So we could take the IVUS, we could take the IVUS catheter, and then we'll do an IVUS run. I'm going to do it on the rota wire. I hope it'll pass. If not, I'll have to exchange for a normal wire, and I'm trying to save myself.
Now, IVUS versus OCT. Your comments, please.
Is this for me or for the panel?
No. anyone who is in your lab, do you use OCT also, Mohamed?
I have OCT, both of them. I was going to do both. As I said, when I did the angiogram in September, it was okay, and I thought this is a good case to do OCT, to do orbital atherectomy, everything. But today is completely different, and there was no chance for the OCT to come and do anything, even the IVUS. So, and now with the dissection, it's questionable. Hold on. Sorry?
I think that's a good point. I wouldn't use OCT in this case, given the osteal dissection. I'd be using IVUS.
Okay, hold on to
I think I the imaging need.
Yes, I agree with you, Jenny. It is just for the fellows because OCT is otherwise not for this case, but generally that can see more depth of the calcium and more details. As opposed
it will be, yeah, absolutely. It's much better for seeing sort of superficial versus deep calcium and the depth and severity. So I completely agree. In routine practice, OCT would be ideal, but in this particular case, and as you're saying, it's how cases evolve, don't they?
Yeah, the time is the essence, and Mohamed has got great tolerance for these challenging cases. I have seen.
Keep coming. Yeah, I mean, this, to be honest, I had the OCT ready. I was going to do both OCT, because both of them are valid. Both of them give you good information. Can we go live? Can you see my IVUS now? Can we take the feed from the IVUS machine, Paul, please? Oh, here we go. That's my IVUS in the screen, yeah? I'm hoping this will go. I don't know where it is. Inside the artery. I don't know how far, to be honest. This X-ray is horrible. Okay. So I could see immediately some fractured calcium there, but let me just go a little bit further forward. One option, to be honest, and this is for the juniors and for the trainee. If your IVUS is not going on any wire, you could take a balloon, a small balloon on the wire, and push it all the way behind the IVUS and push both the balloon and the IVUS, and they will go. Now we are in the mid RCA, and I'm going to start a pullback. I'm going to flush this catheter and start the pullback to see the rota effect on this. Here we go. So, would anybody like to comment on the IVUS, or do you want me to?
You can see the most part is from 12 to 7, a lot of calcium.
Yeah.
And there is some.
So this is beyond the lesion. I haven't rotablated there. Now we're coming to the proximal part.
The vessel size is more than 4 millimeter. Now it's very circles.
This is 360 degree. There's fracture in some of this calcium.
A crack of superficial calcium.
I think very proximally, just when you started, I was saying there was a good 360-degree arc of calcium which had no fractures in it. I think just at the very
yes. So I think for me, looking at this now, the next step will be to take a non-compliant balloon. Then I'm going to need a guideline, take an IVL, and then treat with the IVL, because I think taking a bigger burr here is could be hazardous, and I don't want to put the patients through any possibility of problem. So I think that's what we will do. So I'm going to have a 3.0 by 15 or 20 non-compliant balloon. Is this stuck? It's not moving, or is it moving? So proximally, there are two areas of concern here. As you can see, we're coming to the proximal area. The calcium is fractured, which is very good.
And you could see the dissection plane in a couple of frames before, like had a double lumen there.
Look at that. I mean, there's a calcium nodule here also. This is proximal. And that's the hematoma. That's the dissection. It's from 5 to 7 o'clock, and you can see the hematoma. But we will deal with this as we go along. It's not an issue for now. We could use a cutting balloon, so it doesn't brace. Okay, this is coming out now.
So why don't you do an NC and then a cutting balloon only?
Yeah.
Do you think that maybe leave IVL? I don't know. Let's see how the case goes.
Yeah, I mean it is an option. Obviously, if I any concern, I'm not going to push for something that should not be done. Okay. I'll stop it here. And the IVUS now went on even on the oh God, it's stuck on the rota wire. So we have done something with the 125, that's for sure, which is good. So I think I'm gonna swap. Sorry, I'm gonna swap this rota wire and work on a different wire and do as we said, we'll take I'll take a non-compliant balloon. Then we'll see, maybe take an IVL, because I don't think this lesion is prepared well enough to just put stents in. Cutting balloon may be okay, but yeah, go on.
Monad Nadeem here. Now, in your experience, because you do IVUSs after everything, in my experience, I've hardly used 1.5. I normally modify it with 1.25 and usually get enough space to get a stent in and well expanded, and the results are usually okay. But in your experience, because you do routine OCT and IVUS, once you crack the intimal like you did here, how much problems do you have in upgrade? I mean, if you upgrade versus no upgrade, just NC and stent, what's the difference?
So I started, there's a lot of debate about this, and a lot of people say, yes, you use a small burr to modify. I published a series long time ago. Only it was 29 patients. 3 of them, we did the same, modifying the calcium only with 125. And 3 patients within 6 months came back with stent thrombosis or restenosis. And when you IVUS them again, under-expanded, under-deployed. If I'm going to modify the calcium, I want to make sure that I've modified the calcium. 125, some cases it might work enough, and then you take the balloon and the IVL. The majority of cases, particularly what we see, I mean, a case like this, and you look how much calcium, the chances of 125 being enough are very slim. I am a believer. I am a believer. Yeah, I'm a believer in taking a bigger burr and modifying the lesion properly.
No, this is what I'm asking. At the pathology level, once you've seen the IVUS here, it's cracked open the intima and there is calcium hanging here and there. What further modifications, or with a bigger burr, what would you expect? You'd still have even more cracked calcium floating around, bigger hematomas. And so you've already cracked the intima.
Yeah. So what we've seen here, couple area that's still 360-degree calcium without much break. The break was before it and after it. And I'm hoping, because it is short, that we should be able to, because it's a short area of this 360-degree calcium, we are going to be able to break that calcium and hopefully not need any more of this rota burst. The problem is, if this doesn't happen, this is the fielder, right? If this doesn't happen, then we are stuck and we're going to have to repeat but we have the option of the IVL. So I think looking at this, we should be able to crack it. Of course, we have OPN. We could use OPN on a bend with this kind of artery. A bit risky strategy, but it can be used. And the OPN, just to mention this for people who don't use it, it doesn't get used very often. But if you are going to use it, it's about undersizing. It's about the pressure, not the size. So you start with like 0.5 of the artery rather a small 1-to-1 in order to prevent any breakage of the deflator, please. So now the Corsair went without any problem. Sorry, go on.
Oh no, I was going to say I completely agree with it, and I think that's where the beauty of IVL comes in here. Is it you're using very low pressures and delivering therapies? It's a very safe option given the tortuosity and the level of calcium that
16.
there is with both spicules and
Can you give me 50 fentanyl, please?
disease. My worry about OPM would be perforation. Worry about bigger burst size would be
absolutely.
Worse than dissection. So I think IVL here will provide a very safe strategy.
Yeah. I mean, this is absolutely my thought. As I said, the anatomy changed, or the lesion changed dramatically for the last 6-7 months, which is not unusual, but I didn't expect that, to be honest, because I said I'm a bit disappointed I did not demonstrate to you the orbital atherectomy, but it is what it is. It would have been perfect with the tortuosity, but the lesion wasn't as bad when we did it before. And I thought orbital atherectomy would be okay. Then, of course, we were faced with this dissection proximity that makes life a little bit more difficult. I can't see very well here. Can you just go a little bit more, Leo? Move the spine away.
Anyone from the panel experience of using
good.
IVL in tortuous vessels like this?
Okay, go up there.
Dr. Chu,
No,
Dr.
I
Zain,
think,
IVL.
8, 10.
Yeah, we do, but we know it's the profile of the balloon is really
It's a 3-0, yeah.
how to maneuver through such tortuosity.
12.
Very often you're going to need to prepare the lesion well. You might need some guide extension to deliver the balloon down.
Can you see the balloon? It's expanded not reasonably well. There's still an area very little, just around the bend. Okay, that's not yet. I was going to give it a little bit longer.
What size balloon is that?
This is only a 3-0. Okay, go up. Only a 3-0.
Do you not think that's under expanded? Therefore, do you not think it's restricted expansion?
Yes, restricted expansion. Yeah, it looks very small for the Sarti. I know the Sarti is much bigger than. 10, 12. And one thing we do in these cases, and this is what I do, majority of pre-dilatation or post-dilatation, a little bit more. I go up to 10, 12 atmosphere or 8, 10 atmospheres and wait and go slowly up, just to give the RT a little bit of time to adapt to kind of accommodate and down. What happens, people just put the balloon in and wang it up to high pressure, and what happens is just to break it. And the analogy I use for the trainees is like when you take a cold dish and you put it in water, it'll crack immediately. Warm it between your fingers, go up, warm it up a little bit, and throw it in boiling water, nothing happens. And this is exactly what we do with the arteries here. So give it a little bit of time. And the other thing is, once you store that, once you go up, you never can come down, but you could always go up more. So slowly and gently, 16 and down. We take our time, we make sure that the artery is responding to us, we don't cause any perforation, any problem, and then we deal with after that. So here we are. This is what you could have a look and see with the IVUS if guys want me to do this, or shall we just go with IVL and get this sorted out? You want another IVL, yeah? Okay, so that.
IVL, yeah.
We have 15 minutes more.
I personally, given the expansion, would go for IVL.
Sorry? What did you say, Jenny? I didn't hear the last comment. The other thing is also, what do you use with IVL? 3.0 or 3.5? We all saw that 3.0 is a little bit small, but nonetheless, the lumen would be more than enough.
I think 3.5. Like you've done already done a 3.0 and see it was like pretty restricted, and we know the lumen is pretty big. So
yeah, so take a 3.5. That's my thoughts actually. We have to be again at a low pressure. Just last week I had the IVL rupture at 4 atmosphere in the proximal LAD after delivering two trains. So it's interesting.
And there is advantage of undersizing that the problem of profile. So
absolutely. I don't think the profile is that different between the two. However, it's one of these that you again, undersizing and being safe is the better option always.
Mohamed, I had a few of these IVL balloon ruptures as well. Do you think it's the inadequate preparation to some residual, maybe air in the balloon or something that's causing that, or the bone spicules?
I think probably I always thought about it as when you do the IVL and even 4 and you go to 6, if the calcium has been affected, you might break it and cause a little speck of calcium. But that's me thinking that way. I don't know.
I've always presumed it was spicules. I try and only go up to 4 atmospheres. There was an initial trend for going up to 6 after the delivery of the pulses at 4. But I've tended to find initially that was when you were getting some perforation. So I tend to stick at 4, and the company have sort of agreed with that as a strategy. So I hopefully go 4 and try and limit that. But only the other day I had one that still burst on second 10 pulses at 4 atmospheres, and I think it's speculation, as you suggested, Mohammed.
Yeah, it's always safer to be at the low pressure because I mean, to be honest, I have used IVL when I went to up to 8, or in a big artery when you use a small balloon, but that's not recommended. And these did not rupture. The one that ruptured with me are the one that we stayed at the low pressure. But a calcium like this, I'm hoping this will go. A non-compliant balloon, I tried it even after inflating and it was going down. So hopefully this will go. I don't know. If it doesn't, then a guideliner is on the card here. So let's see what happens. Can we activate? Can we activate the
company's
IVL.
advice is if you take an unfurled NC of the right size round, then you should be able to deliver the IVL, and I think that's pretty true.
Well, not this case. But we could start proximally. I mean, I am on a fielder FC, let's face it. And it's, let me just push this down a little bit more and see if I could. No, it's not going. So I think I'm going to start here. Just go up, go to 4 atmospheres. You go up 4. I'm going to take a cine, show you the status of the balloon.
Do you find good success, man, with the edging technique here, where you almost, although you'd ideally go,
has it ruptured?
It's ruptured.
Has it ruptured? It's ruptured.
Yeah.
Come off. You saw the dye come down. It has ruptured. Let's make sure the artery is okay. It was only 4 atmospheres, so store that. I think it's ruptured. Let me just try it outside the artery. It's ruptured. How high did you go? Yeah, that's right. Okay. So it came down. I didn't want to go any further. I'm gonna have, yes, it's ruptured. Can I have another one, please? Wow. There you go. And I'll have a guide liner. I mean, I suppose advantage of taking 6 French that could go further, but 6 French delivering some of the balloons in these torch was in the guide might be a little bit problematic. So 7 French, yeah. And also for the IVL balloon, you need a bigger lumen. Sorry? Yeah. We could take a 4.0 actually, but I think I'm going to be conservative. I'm not going to go to because also here I'm looking at this, and now my aim is to achieve a decent lumen rather than you know, big lumen.
So I believe the company say that you should be able to get a 3.0 shockwave through a 6 French guideliner, but as we're going bigger than that, I agree with you, I'd stick with the 6 French guideliner. Yeah.
The same thing also for this. Of course, it might not go as distal, but you know, it's we just have to manage as much as we can. If not, then I'll have to take the non-compliant balloon, take the guide liner down on top of the non-compliant balloon for the distal lesion, and then do it that way. But let's.
So sometimes I found doing the NC first to high pressures causes deformation and structural change. So you lose that, you almost get the dropping down of calcium spicules in your way, which makes it less deliverable than it was when you took the initial device round, having created the path from the
absolutely. It changes. So this did not go. I'll have to look why this hasn't gone into the guide liner. And as we said, just fix the wire for me. So here we go. That's better now. So trying to put the 3.5 IVL, I only put the guide liner inside, and the rod, the balloon would not pass the rod out inside the guide. So I've just taken it out and deliver it inside. So let's connect in here. Yes, this is a kind of a hair raising, in a way, it's quite a difficult case, but roll this back. Okay.
Sorry, Mohammed, what wire do you have in now?
It's a fielder FC. I mean, I could have taken a more, because I've got the Corsair. I could have taken BT Choice extra support or some more.
Yeah, something like that. Yeah.
So the other,
something like that.
The other option, I don't know if people are using it. We have the wiggle wire. The wiggle wires are quite a very good wire also to to use in cases like this. Is anybody using wiggle wire? Are we familiar with the wiggle wire?
Yeah, but I think a Grand Slam and an Ironman, because
Yeah,
they're
I
really
think
big tracks,
yeah.
right? So I think wiggle wire, because of it bends, would help, but I'm not sure with the stiff shaft of the IVL catheter how much.
Yeah, I mean, it
support
does
that.
help in the way, because it's got bends on it, deflects you away from the. Oh wow! I mean, okay, a little bit better. Just advance the guide liner a little bit more. Can you see my screen? Apologies, we can't go on
So we can see
blankly
that.
on bigger. So the guide liner is doing a good job.
Oh, your guide's right out.
I want to lose my equipment because a lot of resistance, and when it comes down, we push. So let's go up there. Go up to 4 atmospheres only. I'm going to pull my guide liner back because there's no blood going. Dynamic is okay. 4 atmospheres. Here it looks better, expanding better, but yeah, this is a very resistant artery. Okay, come down. Don't go up. Come down. Don't go up. Thank you. See if we could advance it a little bit more. I don't think we can. So we're probably going to have to depend on the non-compliant balloon here. Wow, it's not going. So that was gone around the corner. That's a good sign. The 7 French has gone. Let's see if I could deliver this IV a little bit more distal. Wow, it's not. It's pushing. Go up there again. Let's just do that one more time. 4 atmospheres only. All right, sir. So this is expanding, okay. Okay, come down. Don't go up. Okay. He's having a lot of chest pain, obviously, with this because we're blocking the artery completely. But let's see if I could get this a little bit further down. So here we go, and let's see if this will go. Okay, the problem is unfolded now, and it's not the friendliest of. Here's my wire down. Let's see if this balloon will go a little bit better. Okay, go up there. Go up 4. Is that some fentanyl? Yeah. Can I give him another 50, please? Okay, down. All right, sir. Just bear with me. I'm going to give you some painkiller. Just bear with me. You're doing very well. I'm just going to test and see what I've got here before I go any further. This chest pain is not a good thing, but wow. Okay. Still haven't done the proximal part. Here we are. Was injecting through. Okay, store that. That's not a problem. I think we hopefully have some effect, but we'll see. I'm going to do the proximal part because that hasn't had any pulses delivered, and if we need to do something after, we'll do it. Here we go.
Any ECG changes?
Up there. No, it's stable, hemodynamic, a little bradycardic, which is not unexpected. You're going, not unexpected, but again, proximally it's expanding. So I'm going to move it just around the bend, do one more run, and then we'll take a non-compliant balloon, bigger one, and then okay, come down. No, don't go up, please. Don't. I know, but it's not. We don't want any trouble now. 4 is more. Sorry? Yeah, 50. Just gonna give you some more painkillers, so just bear with me, okay? You're doing very well. Your RT, as I said to you, is not the easiest. It's hard like a rock. Okay, I'll just pull this back. So I'm just trying to do that area on the bend. Okay, go up there. 4 atmospheres. Okay, these seem to be expanding nicely. I think we're in a good shape here. So, okay, down. Right. I think I'm happy with this for the time being. I think we should just start ballooning one more time with the 3-5, see how that expands, and hopefully take stents and be done in the next few minutes if we haven't caused any havoc.
You want to take any picture?
Yes, I will take a very short. The guide liner is inside the artery, so the dissection proximally is a little bit protected. Nonetheless, it is always potential to, so really injecting very gentle because the pressure also is low, so it could lead to dissection. Here we go. Let's have a look. Okay, here we go. So that's more than enough. There's a small branch that's gone there, which is okay. Fine. Okay, let's have 3520 non-compliant balloon. And I'm going to take this out of the ostium. Let the artery drink some blood more. Can see some dye hole there, but that's okay. We know that there's a hematoma and a dissection. I think we're so far so good. Any ideas on it? Would you like? I suppose I'll do the 3-5, and then we do an IVUS run, and then we could go with the stents.
Yeah.
Don't forget, there's a lot of disease distally, but I'm not touching that. Just around the bend, there's an area of about 20 millimeter of probably significant stenosis, but heavily calcified also. And I think that's not a target for now or later, unless he's absolutely symptomatic. He came back for this because he was still having chest pain, and we knew this from the beginning anyway. But so far, this is...
Sometimes there is some distal embolization, maybe.
Sorry?
Sometimes distal embolization can cause this pain if it is.
Oh, sure. But I think it's the stretching and the blocking of his artery, and he's settled. He's not. We've given some fentanyl, and let me just see what we could do. So the 3-5 non-compliant, you're getting stuck a little bit here, but it is going. Just go back one for me. Okay, so I need to go a little bit further just to get this. Okay, we got the guide liner in. It is still getting gripped, but with the guide liner, hopefully I could push it a little bit further down. Just 1 second. Go back one. Yeah, okay. Okay. So go up there. Up to 6, 8. Slowly we'll go up with the pressure and see what we get. 10, 12. So here, this 3-5 looks quite expanded nicely. 14, 16, and down. Yeah, I think I'm happy with that. There's still a lot of calcium, obviously, but and after this kind of inflation in these arteries, a little test doesn't hurt to make sure all present and correct. Store that, because sometimes you do this and you have a perforation, and by the time you finish, everything is hosing out, and it's not okay. Let's go up there again to 6, 8, 10, 12. Okay, right. The question for you guys in down. Is there any preferable stent in cases such like this, or what do you guys do? Or does it make any difference?
Yeah, I think if you're thinking of delivery as an issue, then probably a synergy or zero. But I think you need a good bit of radial force as well. So probably for me, a Zions probably will be the one 16. That I choose for this one.
Okay. Any other suggestions? And down.
I mean, you could take the guide liner to the med and then unsheath the stent. So any newer generation stent should do. I wouldn't try to push a stent through, or use balloon anchor to get the guide liner to med RCA and then unsheath whatever stent that you fancy.
Yeah, sure. I mean, this is my thought. I don't think the stents make too much difference. I always say, current scrub of stent, you put them in boxes, mix them up, and hand me anyone. In 95% of the time, it all works okay. Now, maybe we should deliver. Let me just put leave it, keep it connected. In maybe, not sure there's much difference in the two. Deliverability, again, very comparable. So, it's all much of the muchness, to be honest. But so I've got no issue here. People talk about also osteal lesion, trying to not to use certain stent. And I don't think that's a factor of stent. It's a stent deformation with all kind of stents. Every single stent has had that. So, yeah, I don't think it makes so much difference. I can't remember what we used in last. The other thing is also I'd like to ask and see what you guys think. Do you think it makes any difference if you've used a certain stent? So I was asking that question. If we've used a certain kind of stent, go back one. Does it make any difference if you change the type of stent in the second procedure or not? Now go forward one.
I personally wouldn't think twice. I'd be using.
Go forward one, please.
I thought was right for the
back. So we missed it. Okay, back.
The lesion that you're dealing with. I think you're right. What the other guys were saying here. I probably wouldn't go for thin struts just for radial strength, but I'd go for sort of any of the other standard generational stents. So I'd put science in here. I probably would avoid things like Megatron. just because of the slight extra thickness. I'm slightly worried about still under expanding within that area and also deliverability.
Yeah, I mean, I think I'm gonna stick with Zions in this case.
Yeah.
So I think a 3.5 by, sorry?
I was going to say I probably wouldn't be worried about what I'd done in the previous vessel. I've just
just out of interest, particularly sometimes mixing the medication or mixing the stent in the same setting. I don't think it makes too much difference. Although there has been 1 or 2 cases where there's some allergy because you've got a different polymer, different kind of additional to the. Can I have a 3.5 by 20?
Mohan, may I just sort of clarify that having seen the balloon expansion angiographically, you're happy with the preparation of the vessel, or you still want to have imaging to decide whether you've prepared the calcium enough before putting in the stent?
I mean, am I 100% happy with the vessel? Absolutely not. A little bit more can be done, but perfection is the enemy of good. And I'm also conscious of how, if we are going to go for a bigger balloon or bigger, something else, I think might lead us to problem. As I mentioned, at woman is more than good, as long as the stent is deployed and so you get it ready. Don't worry. Yes. I could accept that, and I was gonna IVUS, but also I'm conscious of the time for you guys. I don't want to be. I wanted to see the final result before we go. Don't forget sometimes. Yeah.
10 minutes how long? Sure. We have 10 minutes more.
Yeah. Don't forget. Sometimes perforation can happen after. Let's let the while go. Perforation can happen after you put the stent and you post dilate. And I've seen this more with orbital for some reason, and I don't know why. Look at that. So, but I didn't. It's not unexpected, I suppose. And this is what was mentioned about. So it might end up just putting it in the proximal part in the ostium if this doesn't go in the next couple seconds. My guideline is on top of it, so hopefully it will go without stripping it, because you worry about stripping the stent, obviously. So hopefully we could. If I need to dilate a little bit more. Can you go to LAO caudal for me? And just focus on the ostium. A bit more caudal, unlock.
Would you have some apprehension positioning the stent proximally and with then given the aggression that you're probably going to have to do to get stuff around the bends?
Yes, I mean, it's one of these. I'm thinking if I deploy this properly, if I need to bust dilate it, then take the guideliner all the way down, then take a second balloon if I need to but absolutely, I mean, you're absolutely correct. It is something that we have to be a bit wary of, but I think probably be okay. Famous last word, obviously. I'm just going to lift the guide up.
Yeah, be careful your guiding, maybe too deep.
No, exactly. It's store that. I need to come back just a notch here so I could cover the ostium and cover the flap that we created. So I'm going to build this back a bit. Okay, test there. I'm going to test. Okay, just go up there.
Myself and Jenny both are on ward round.
When we do a stent in the ostium, once the balloon is up, I'll inject. Okay, store that and back to LAO. Yeah, 10, 12. You could see it is a bit shorter stent, but that's okay. I took it on purpose because a longer stent would have been unlock, would have caused me more problem. So if I need to, okay, hand down.
Shouldn't you have brought your stent around that bend? That S seems to be missed. Now you're going to have to navigate. Should you need another stent?
Yes,
which you would most likely. You've got some stents hanging out in the aorta.
But it's very little. I mean, you saw with the, it's, so if I get I'm just take a little test here. I'm going to build the balloon back a bit and probably pre-dilate also distally a little bit more. Okay, store that.
Our webinar time is over. So anyone who has overriding appointment, so he's most welcome to UC leave, but we'll be happy to continue for another 5-10 minutes.
Yes, okay.
Jenny, probably you're getting some calls from your work.
We should be done by then. There you go. Just connect that and go on negative for me. So yeah, now I mean the guideline that gives you a little bit of kind of sometimes false sense of security, to be honest, because you're absolutely spot on when you have, particularly in certain kind of stent, you could have some protrusion of calcium or the blacks, and that makes life a little difficult when you come to deliver other stuff. But in general, it does help very, very well. So I think from that respect, I'm happy how things are going, but potentially we have to be on our toes to make sure that we don't lose perspective here. Okay, go up there. I'm gonna get the guideline a little bit further distally. Don't go up, it's okay. On top of the balloon, and hopefully that will allow me. I think we need to prepare this lesion, so I'll bring this guideline just a nudge, and okay, and here we go. Go up there. 12, 14, 16. Okay, and down. See if we could inch from this guideliner down. Here we go. I think we should be able to take. So go back one. Can I have a 3.5 by, I think 30? What did I? Oh, here we go. Thank you. 33 by, probably 3.5 by 33. We'll make it 38. I'm not going to whinge. So after all this work, I took the guideliner out. So there you go. That's all right. We'll do it again. Done it once, we'll do it again. So let me just do this again and suck it in. Okay, go up there. Yeah, 38, please. 16. Okay, and come down. I thought you guys might need some more to see more of this, so I did it, took the guideliner out. Go up there. Just to do it again, so it's more.
It's a nice technique to demonstrate to the trainees on the call, Mahaj. Nice technique to demonstrate to the fellows on the call of deflation of the balloon and bringing them.
Yeah, yes, and you bring the guideline on top of it. Sometimes you don't need to inflate, but in case like this, you have to. But sometimes just putting the balloon could allow you to do it. But here we are. Okay, so now I'll take the 3.5, and hopefully this will just run through, and then we put the stent IVUS and post dilate as we finish, and show you a good final result, I hope, without any holes or any.
No, I think you have done extremely well, very confident and on spot.
Yeah,
it's a very difficult and challenging case. We know the tortuosity and the kind of calcium it has. When I saw your pictures when you sent yesterday, I thought it's not a case for showing on the live. But anyway,
well, I mean, it's one of these that, to be honest, yeah. The point is, yes, you're not trying. I said when I saw it before, the angiogram wasn't as bad and the RT wasn't as bad. However, things have changed, and in the same token, it's not. So we could see that it's very good here right now.
Well.
Yeah. As I said, give you. I think we are overlapped here. Let me just move this back. I'll just take a little test. Okay, that's good. Go up there. Put up to 8. So yes, cases like this, but this is what we are dealing with on a day-to-day basis almost. 10, 12. Yeah, it's not too bad. Not too bad at all.
Very nice.
Yeah, nice expansion.
Yeah. Okay. 14.
So for
16.
understand how long you were deployed.
Sorry?
15. How long you were deployed then? Yeah, longer.
I mean, for the longer stent, you try to be a little long. Because often there's a small evidence like 20 seconds was better, but I don't think it makes too much difference. But it's better. I don't like something on the inside here, but let's have a look.
You have covered the osteum as well?
No. Yes, the osteum is covered from the previous one. So I think we do have a little bit of intimal, or is it a perforation? I'm not sure. Come to RAO. Come to RAO.
There is some maybe perforation.
Yeah. Yeah, I think it does look like, come here for me.
I think
go to RAO with the cranial, a little bit cranial, RAO cranial. Go.
Ready with the covered
stent. It's okay. I mean, the balloon is still there, and this is one of the crucial. Yeah, it's not much there actually, but we have to be cautious. Go back and go to LAO. I always, in cases like this, before I remove the balloon, I always test. The last thing you want to, you move the balloon and talking to everyone, you turn around, there's a big hole. I am not sure this is what this is, if I'm honest. I think I'm going to have to move the balloon just a little bit back and see. because sometimes also if there's a perforation and your big unfolded balloon is in, you don't see exactly what's happening.
Is it a stent fracture or something? Probably IVUS can show. Or...
I'm not sure it show you perforation. Well, you could kind of anticipate there are some things you could look for, but okay, I'll just leave this closer here. I'll just move this here and I'll build the balloon back. If I need to return it, then I will use the guide liner. So we need the 3.5 ready just in case we need it. Nah, it's okay. There is a little bit of
it's a branch or a stent fracture.
On the setup shot, there's a branch coming towards us. I think this is absolutely fine. I think it's okay. So I'm happy with that. We'll take the IVUS, do the IVUS distally, and then see if we need to post dilate or not. Yeah, that is our thing. So yes, I mean, you see that. I mean, luckily we have the tools to deal with with all of these cases, if I'm honest, but it is learning, kind of taking your time and mastering most of the technique and the little tricks and tricks.
So what are the views of the panel think? Is it fracture, perforation, or dissection, or?
I don't think it is. I think there was a branch there, at least looks it, but I am keeping an eye on it because sometimes like this, and that could even kind of makes us think about whether we need to post dilate and what we post dilate with.
Exactly, I would be concerned about post dilating
before, absolutely, but I'm hoping that because we went to 16 atmospheres, so I think it should be okay. We put a new one.
I think it's a severe dissection involved with the external. Yeah, maybe we
probably.
can show the limits. Yeah,
probably.
Then make
so,
maybe I will avoid post dilation.
Yeah. We will see if we need to post dilate or not. I am not. Oh. Wow, the IVUS is stuck in here. Let me just get the guide liner down. That's why you're not seeing the artery proximity. That's the guide liner, but I thought it's going to be troublesome, but let's see if we could deliver it there.
Okay, nice. IVUS.
Gonna put the guide liner back so we don't have to be stuck with it or inside it. And then I will do the run for you and then see what we've got. I suspect we're going to have all good, no issue, but okay, here's the run back.
What kind of IVUS do you have? I really like your images. They're very crisp.
And we'll be reaching the stent in a second here. You can see there's some disease distally that we haven't, I'm not even going to go there, but here we go.
Very large lumen.
Yeah, and this is the whole thing. It's not about achieving the typical size of the artery. Now we achieve a good lumen. That's more than enough. Perfection is the enemy of good always. Here's the stent, very well deployed. I think a cross-sectional area will be at least 7 or 8, hopefully. There's 1, 2, 3, 3.5 in horizontally, about 3 in this area. This is where we saw heavy calcium. This is just.
The question is, was that an area of malapposition or is that a area that we're seeing?
Yes, I think that's the hematoma.
Yeah, that's severe hematoma.
Yeah, and we saw it at the beginning anyway, but I think we could leave it well alone, unless you guys think something needs to be done. Looking at the angiogram, we'll do this in a minute. It's STIMI 3 flow. It's all doing good. I think I'm very happy with this, but what do you guys think? We still haven't finished it. We'll see it when we come back.
I think then maybe after finish your case, you do the
very proximal and
just the echo to rule out any after the procedure. I think
to rule out.
I mean, if there is any fusion or.
Sure. So I don't think there is, and quite often in cases like this, angiographically, if there's any contrast, you see it in the pericardium. Particularly, I mean, a perforation here would be quite huge. Because the artery will rip. It's very, very stiff artery. But we keep an eye on this definitely and see.
So any question or comments? I know that we are overshoot and we have already overshoot the time. So thank you so much. I must congratulate you, Mohammad, for this wonderful case, and everyone enjoyed this demonstration, and we learned a lot from this live case on coronary calcification. And then we are also grateful for all the panelists who joined us from all over the world, from Malaysia, China, Pakistan, and United Kingdom. And our thanks are also due to these nurses and technicians who helped in this case, and especially the audiovisual team, Mr. Mudassir from Pakistan and Paul from United Kingdom. And then last but not least, this webinar would have not been possible without the support of MI-CathLink, sponsored by Highnoon Pharma. Thank you very much, everyone. Bye-bye.